Category 1, Part 2. Category 1 is the most basic category in SOT, and it relates to part of the theory of SOT, that there is a pumping mechanism for cerebrospinal fluid around the spinal cord and the brain, that CSF is contained within the dura mater, and that dura mater is tensioned by slight motion of the sacrum between the two ilia. That motion is afforded by the synovial part of the SI joint. That research tells us allows 2 to 3 degrees of rotation and maybe 2 to 3 millimeters of translation in any direction. The relationship of the Category 1 part of body physiology to Category 2 and 3 is well established within SOT. At least part of this theory came from the fact that Dr. DeJarnette was also an osteopath, and one of his teachers was William Gardner Sutherland, who developed the methods of craniopathy, the analysis and adjustment of the cranium, as it relates to the dural structures and the cerebrospinal fluid. We do a prone leg check in SOT, whether we're doing Category 1 or Category 3. DeJarnette felt that tension, distractive tension or traction, applied to the legs gave him more of a visual difference between the short and long leg. What I find is that you can actually feel the short leg, even in the prone position, if you place your thumbs just above the medial malleoli and traction down. Bring the thumbs together. I'm not showing the thumbs together in this slide, but you can bring the thumbs together. See what you feel and take a look and see what you see. Okay? So this is a different way of doing a leg check. In order to use the blocks in the Category 1 prone position to correct the sacroiliac dysfunction and sacral motion, you have to make sure that the short leg is on the side of greater heel tension. If it's not, you must adjust the atlas first. So if you find heel tension greater on the long leg side, adjust atlas first. This is a picture of an uncorrected and actually a corrected Category 1 blocking procedure. The white block with the dashed line around it is actually the correct blocking position for the low block. I took this picture originally standing on the table. You can see the toe of my right shoe below the board on the right side there. And I didn't notice that the blocks weren't facing each other directly. They should be. So I've repositioned the low block in that white position there. And what we're looking for is, first of all, this patient would have left short leg and heel tension on the left. Within a couple of minutes, you should notice that heel tension is decreasing palpably. And that's a really sort of neat thing to look for. The legs should balance almost immediately. If they don't, you've probably blocked backwards. Make sure that the low block is facing up directly at the high block, with no angulation and no offset between the blocks. You're going to leave the patient on these blocks for probably a total of about 6 minutes, but after 4 minutes, you're going to go on to some muscular balancing procedures in the lumbar and pelvic muscles. So Category 1 blocking is done prone for approximately 6 minutes. This is a self-adjustment by the patient to their own SI joints, to the part of the SI joint that is synovial, that actually has a synovial capsule that allows the sacrum to move somewhat independently of the ilia to a very slight degree between the two ilia. That should take some stress off the dural attachments to that sacrum, and that should remobilize the sacrum to whatever degree the synovial joints will allow motion to occur. That will allow that sacrum to help pump cerebrospinal fluid, not only during walking and running, but during breathing. So theoretically, the sacrum moves a little bit 24 hours a day as long as you continue to breathe. And that motion imparts some pumping to the cerebrospinal fluid throughout the spinal cord and the brain. So breathing provides the motive force for not only CSF flow, but also the motive force for the patient to realign their own synovial joint within their SI joint. That's the part that's anterior and more inferior to the weight-bearing ligamentous part that we're more interested in category 2. I state that the patient is passive during block placement, which means we lift the patient off the table to place the blocks. We lift one side at a time, we put the blocks in. The patient doesn't help us. So, since the SI joint has two separate functions, one of which is support, that we're more interested in category 2, the other is motion, category 1, you could argue that mobilization of the synovial part of the SI joint is the most important category 1. This is a drawing of what's called the dollar and crest signs. They are palpatory indicators, palpatory findings of a difference in muscle tone above the iliac crest in an area called the crest sign area, and pretty much mid-gluteals, about 2 inches lateral and 3 inches inferior to the PSISs, in an area known as the dollar sign area. The flaccid side, the less tight side, is considered the abnormal dysfunctional side. The tighter side that you might normally think is in spasm is considered the relatively normal side in both of these areas. After the patient has been on the category 1 blocks for about 4 minutes, we palpate these two areas for a difference in muscle tone. We palpate above the iliac crests, lateral to L4 and 5, and we push the musculature towards the spine. And we're pushing pretty much the QL muscles and the erector spinae towards the spine, looking for a thicker, tighter side. And then we tap into the gluteal muscles to find the relatively tighter side. You can also palpate deeper with your thumbs to find the tighter side. In the old days, when exposure of the butt wasn't looked on as an un-American activity, the way it is today, Dr. DeJarnette would actually tap on the butt to find the more flaccid side, the side that had less resilience. That side was the sick side, the other side was the dollar sign side. These days, we're not as prone to do that because we have such a litigious society and we're so uptight about the naked body that we just don't do that normally. Unless the patient is gowned and they know what you're going to do before you do it, definitely. But there aren't too many states where that would be looked on favorably these days. And what we do is we see which area, crest or dollar, has the biggest difference in muscle tone. And we settle in on that area for that visit on that day. So we palpate both areas and then we ask ourselves, okay, is there a bigger difference in the crest area above the iliac crest? Or is there a bigger difference in the gluteal area? And on that visit, we deal with that area only, and we deal with the difference in the muscle tone. If we find that today there's a bigger difference in the dollar area, the gluteal area, We look at that as primarily some sort of a sacral issue, and we keep in mind that the sacrum is the loved brother of the occiput. So this difference might indicate that we need to go up and adjust the occiput craniopathically. They don't necessarily have a PS or AS occiput, but they might need some sort of a cranial adjustment done to occiput to change the way the occiput reciprocates with the sacrum in establishing normal dural tone and normal cerebrospinal fluid pumping. The dollar sign deals with every part of the nervous system except proprioception. So the dollar sign is a very important sign, and Desjardins felt that when people didn't have any normal tone in the glutes, they were flaccid on both sides, that they were really very ill, and his goal was to establish a tighter side through craniopathic adjusting and maybe some stimulation to the dollar area muscles. If he could do that, he was able to help the patient. He also noticed that on people who were really on their deathbed, they had stopped compensating for the stress of life, and he found that they had no dollar sign on either side. They didn't have a normal side. That was a very bad, ominous finding. The crest area above the iliac crest is sort of more mechanical. It relates more to the ilium than the sacrum, and the loved brother of the ilium is the temporal bone, a lateral bone, just like the ilium is a lateral bone. So you palpate in these two areas, and you keep all this in mind as you try to bring up the flaccid side to a more normal tone. So what we're going to do is we're going to do some muscle stimulation procedures to influence feedback from the muscle spindles and the Golgi tendon organs to see if we can balance muscle tone in the low back without going up to the cranial area. Keeping in mind this is done with the patient on the blocks after they have been on the blocks for about 4 minutes. So the procedure is to block the patient according to the short leg and heel tension side, leave them on those blocks for 4 minutes, and after 4 minutes come in and palpate these two general areas. Settle in on either a big difference in the crest area or a big difference in the dollar area. Bear in mind, dollar relates to sacrum and occiput. Crest relates to ilium and temporal bone. So we have some rules on a single visit. Don't try to balance the muscle tone in both areas, just the dollar area above the iliac crest, or the crest, or the dollar area in the glutes, or the crest area above the iliac crests. What you want to do is you want to deal with the tighter side first. It's actually the more normal side. Try to relax it. You're going to do a procedure where you try to get that side to let go a little bit as if it has too much energy. And you're going to extract that energy and send it over to the flaccid side. So you're going to always deal with the tighter side first. Then you're going to do something on the flaccid side to bring up the tone on that side. So if I had 2 wallets in my back pockets, which of course I don't, and I had no money in my left pocket, but I had $20 in my right pocket, I'd want to transfer my right tight side with the $20. I'd want to transfer $10 over to the other side, so now both wallets have $10 in them. That's sort of the idea of balancing muscle tone in the low back. So you could look at this as, if muscle tone is balanced, the adjusting, the passive laying of the patient on the blocks will probably last longer. And who doesn't want to have normal muscle tone on both sides, right? So if you can do this, great. And now if you can't do it, that's going to send the craniopath up to the other end, because we know that we have to go to either occiput in the case of dollar signs, or the temporal bone in the case of unbalanced crest sign. Rule, whoops, I went ahead too far. The third rule is never thrust into a block. So I'm illustrating a gluteal scoop on the left side of the patient here. This would be done for the dollar sign, high block side, because it's away from the block. We're not thrusting into a block. And the right-hand picture is done for a crest sign, high block side, and it's called the ischial thrust. And these are very quick procedures to stretch soft tissue very quickly, because if you stretch GTOs very quickly, they'll change their input. And if you change muscle spindles very quickly, they'll change their what's called their gain. They're adjustable, like the volume on your TV. For this particular course this quarter, I'm not going to hold you responsible for the details about which moves you do for which sign. I usually don't spend that much time on this. Depending on the format of this course in the future, I might spend more time on it. But you're trying to change muscle tone. The slide shows the PSIS toggle. That's done obviously over the PSS to satisfy the requirement that you never thrust into a block. This would be done on the low block side because the PSS is away from the low block. And this would be done for a dollar sign finding. The crest roll is done on the iliac crest. It's a quick I to S thrust off the iliac crest. And it's done also on the low block side, but for the crest sign. And I don't really want to spend any more time on those particular procedures for this basic SOT course. Now the cough test I dealt with also in Category 3. You know that you put your thumb on the spinous of fifth lumbar and get the patient to cough. And if the fifth lumbar bounces straight up towards the ceiling on the prone patient, straight posterior, we call that an SB+. And if it bounces straight up towards the head with no posterior bounce at all, we call that an SB-. And for an SB+, we would traction the patient with 2 high blocks. We contact the sacral apex. The patient inhales, holds it, pulls up, and we push the apex towards the feet. But we do that for tractioning the disc and creating the correct mechanics for good disc traction on a Category 3 patient who we assume has a disc problem. If they had an SB+, we would push on the sacral base while the patient exhales and pulls up. And that would also create traction because we do push in a P to A and S to I drive, but with sort of different torque in the mid-sagittal plane of the spine, of the low back, to create the correct disc traction. On a Category 1, we do the exact same procedures, but we're doing it for a different reason. We're doing it to stretch the spinal dura, not open up the discs. And of course, if you're doing this on Category 3, you're stretching the dura, but we just don't care about the dura at that time. We're doing it for discs. But in Category 1, we're doing it for dura. Are we affecting discs? Absolutely. It's just not our focus of attention at that time. When we do this procedure, here I have the patient blocked for SB+, we're doing it to stretch the dura. And when we stretch the dura, we might get what's called a vasomotor visual response. And if the spine was exposed, if the patient's skin was exposed, they were not wearing a shirt or they were gowned, we would look for an area of decreased blood flow over the spine. Here I have it drawn sort of in the dorsals. It could be in the lumbars. It's less likely you would see it in the neck, but we usually see these in the lumbar or dorsal areas if we look over the exposed skin. It needs to be bilateral, and it'll usually cover 2 to 3 to 4 areas. Might be a bigger area, and you might even have more than one area of blanching. This visual indicator is an indicator of decreased blood flow over the spine in both left and right, be bilateral. And decreased blood flow is the same phenomenon that you measure when you're using a handheld instrument to see heat. This would be a cold area compared to the area above or below. We're not necessarily seeing that it's colder on one side than the other unless the blanching is greater on one side than the other. So blanching indicates decreased blood flow to the subcutaneous arterioles that we're assuming is associated with a subluxation in that area. That subluxation is named the vasomotor subluxation. It's a torquing of the spine, usually with extension malposition, flexion fixation, so it's your typical P listing. And our adjustment, of course, is an I to S thrust to take some of that extension malposition out. Desjardins did that I to S thrust with a knife edge contact. It's good to have the patient lying, obviously they're lying prone. We have the SB plus blocks in to accentuate the dural stress, to enable us to see the vasomotor response. And we have the patient lying on what's called a sternal roll. It's a little canister-shaped pillow to pull the ribs away from the spine and to accentuate the dorsal kyphosis. When you adjust P to A and I to S in that area, and this adjustment is extremely I to S, again, I prefer to use a double hypothenar adjustment. Desjardins used a knife edge I to S thrust. You get a release, depending on how you adjust. A lot of SOTers just do a very gentle, a quick lift. I actually adjust to get an audible. And then if you accentuate the stress again, that vasomotor reaction, that decreased blood flow, that blanching, should disappear or get smaller. If you can't get rid of it in that blanched area, that area of the spine is associated with visceral issues. So, for instance, if it was extreme upper dorsal, I would suspect heart or lungs. Mid dorsal, I would suspect gallbladder, stomach, pancreas, maybe liver. Lower dorsals, I would expect maybe kidneys or small intestines, could be pancreas, could be liver, could be adrenals. So this is the part of SOT where we start to relate the area of subluxation with possible visceral complications. And you know from Dr. Amos's course on subluxation theory that there's different theories of subluxation, such as viscerosomatic, where a pre-existing visceral complication is creating a chronic spinal subluxation, or somatovisceral, where a traumatic subluxation due to mechanical stress develops into visceral issues on the unadjusted patient. So we know that there is a relationship, and this goes all the way back to the first book on chiropractic. And both D.D. Palmer and B.J. Palmer mentioned that you generally can't have one without the other. If you have a visceral issue due to poisoning, just bad eating, allergenic responses to food intake, etc., you're going to get a subluxation if you look hard enough. And if you have a subluxation due to some external force, some traumatic input, you're going to get a visceral issue if you wait long enough. It's just a matter of the sensitivity of your testing and whether you choose to look in that area. So you might accidentally uncover a visceral issue. Whether you do or not, when you look for this vasomotor, it's good if you have natural lighting. You'll see it more easily. There are even fluorescent lights that you can get for your office that simulate natural sunlight way better than typical fluorescents do. You might also use instrumentation to find that blanched area. The next step, of course, if you want to go there, is don't forget the visceral connection between organs and the spine. A lot of people have those autonomic charts in their office explaining the relationship to people, because sometimes your patients will come in with some sort of pain condition, and then a little bit later, when they've gotten relief, they might say, well, can chiropractic have any effect on blood pressure? And you'll say, well, of course it can, and it so happens on this patient it did, because you adjusted upper dorsals or you adjusted adrenals. That might have a direct effect on the ability to regulate their own blood pressure and or asthma or whatever it is. Don't forget the visceral connection. We look for something called occipital fibers, and they will tell you when there's a visceral irritation or pathology. So SOT offers occipital fiber palpation, which is a pretty easy way to determine that you better look viscerally. You better ask the patient some questions regarding their nutritional habits, their special diet, their medications, which could easily be interfering with digestive processes. And SOT offers a visceral care plan called CMRT, Chiropractic Manipulative Reflex Technique, which actually gets into the soft tissue of the organs and gets into reflex braking and tries to affect more normal sympathetic, parasympathetic control of organ function. So we start that with the occipital fibers, which are illustrated here, which are nothing but the tendinous insertions, primarily of the SCM and the trapezius muscles, on the back of the head, on the occiput, from the mastoid medial all the way just about to the EOP. Those muscle fibers bundle up and insert in 7 palpable tendon bundles on the back of the head, and they're palpable with your fingertips. We use our index fingertips to palpate these things, and I'll show you a couple of videos of these being palpated. And they're called occipital fibers, and there's 7 of them. And on this chart, we have those fibers numbered lateral to medial 1 through 7. Fiber 7, they're about a ½ inch apart. Don't go all the way to the EOP. Stop just medial, just lateral to it. There's no muscular attachment in the very middle. That's nuchal ligament attachment there. And we palpate basically on the underside of the superior nuchal line. And we palpate with our index fingertips just off the fingernail. You pluck these fibers like the strings of a guitar. They're small. They're only about 1/8 of an inch or less thick, maybe only 1/16 of an inch. So you can't really use your finger pads. You have to keep your arms out laterally, and you have to pluck across. And you'll see pictures of me doing this, and Dr. Marty Rosen from up in Massachusetts do this also. And you find your fiber on what's called line 1. Line 1 is just on the underside of the nuchal ligament. The fiber that you find will be the swollen fiber that'll be pretty sore to the patient. It'll be twice as thick as its neighbors. All of these fibers are palpable all the time on everybody, or should be, okay? If you find a swollen fiber in this line 1 area, You palpate inferior about a quarter inch to see if that same fiber is also swollen in the line 2 area. If it is, that's really a visceral issue. It's not just a spinal segment issue, it's a visceral issue. The number of the fiber relates to the same chart that we used for trapezius fibers, with a couple of minor differences. But if you had a trap fiber 4 in category 2, you would look to T6 or L2. What we bring in now is we bring in the fact that T6 relates to pancreas and L2 to the cecum. So at that point, I would ask the patient a couple of simple questions. Are you diabetic? Are you hypoglycemic? And they might know, or they might not know. So ask them some simple questions. Well, do you suffer from chronic constipation or diarrhea? That would be more cecum. Do you have a sugar cravings or caffeine cravings? If you don't eat on time, do you get shaky? Do you have general indigestion? Now that all points more to pancreatic. I would palpate in the T6 and L2 areas, see which is worse. Are there any subluxation indicators in those areas? In your SOAP notes, have you adjusted L2 repeatedly? That's cecum. Have you adjusted T6 repeatedly? That may be pancreas. About a quarter inch inferior to line 2, we got line 3, and if you have the swelling going down to that level, that's more really real bad visceral. And they're probably already on medication, or maybe the medication has caused a visceral issue, or maybe they don't even know they have a severe visceral issue. And that's when I would absolutely refer them for some lab work. So tell them they need to make an appointment, get a referral for lab work, unless you can do that directly from your office. So this is a photograph of me actually with my elbows. They're not out laterally quite enough. You have to get your elbows way out laterally like the wings of a chicken and palpate across lateral to medial to find all these. You can't have really long fingernails or you'll stab the patient. These tend to be pretty sore, so it's a good idea to palpate them on yourself, and I usually lead the class through a palpation. This is a drawing of an individual occipital fiber showing line 1 where the muscular tendon actually attaches through Sharpie's fibers into the bone, and that's where we first palpate. We find the most involved fibers on line 1. About a quarter inch inferior is where all the GTOs are, and that's the line 2 area, and then the line 3 area is where the tendon turns into actual muscle fibers. And this is good hand positioning for the palpation of these fibers. You palpate with your index fingertips on line 1, and you keep place with your middle finger. You stretch the skin with your middle finger. These fibers are sometimes less than a quarter inch apart. There's 7 fibers, and you only have about a little less than 2 inches between the mastoid groove and the EOP to get these 7 fibers in. So they're only about a quarter inch apart or less. So it's a very palpation. I used to be a member of one of these helping groups that helped new SOT practitioners or old ones, and we would all write in. This could have been me. Hello, group. New patient, diabetic, failing kidneys, trying to avoid dialysis. I found an occipital fiber on line 2, which is definitely visceral. The first visit, it was found fiber 2. So that's T3, 11, or 12. The following day, again, fiber 2. The next 3 visits, area 3. Okay, so fiber 3. So that's T4, 5, and L1. And T4 is gallbladder. And T5 is stomach. and L1 is ileocecal valve. This is a diabetic, okay? Excuse me, this is failing kidneys. Well, line 2 is T3, 11, and 12. That makes sense. T11 and 12 is kidneys, but then it changes. And repeatedly, this patient had T4 pain on palpation. So she did gallbladder CMRT. She did this reflex braking advanced SOT procedure for gallbladder. The blocking has gone as far as it can. This is a Category 1 patient. Any suggestions? So people wrote back, including me, and I wanted to make sure that the patient really was a Category 1, although in a way that doesn't matter, because a Category 2 or 3 can have failing kidneys. There's nothing to prevent anybody from having a visceral issue and also having a bulging disc, okay? But the patient really was a Category 1. She had A to P sway, bilateral first ribs, right heel tension, negative arm fossa. Charles Blum, a very experienced SOTer, wrote in and said, well, you know, there's a relationship between the psoas muscle and the kidneys. Now, she didn't want to do psoas stretching because of abdominal inflammation, but there's other ways to get the patient to stretch their own psoas. Ned Hazy, who is an amazing SOT practitioner, he teaches at Cleveland, Kansas City, and he actually did adjust Dr. Desjarnette many times and learned from the master since he was a child, because Ned's dad was an SOTer also. I had the honor of teaching with Ned occipital fiber palpation actually not that long ago, and it was really sort of like having Desjarnette there with us. He said, hey, if you're finding fiber 3, which is being called area 3 here, do CMR to the gallbladder, do CMRT to the gallbladder. And she has been, and the patient is responding well. So this is a good lesson in letting the patient show you what's really wrong and believing them. And even though you might not see the immediate relationship, keep this in mind. The kidneys function very much in line with the liver. And gallbladder is sort of a victim of the liver. And this patient is saying, relieve my gallbladder, relieve my gallbladder. And that's what she's doing, and it's helping. So that's cool. This is Desjarnette's version of the Merrick chart. The Merrick chart relates to the vertemirs and which vertebra relate to which organ system. This is the chart I need you to know for this course. I found it to be highly reliable. Highly reliable. And this is a good thing to show your patient. Patient, I know what you're having is like lower neck, upper mid-back stuff. And I know it's tight, and when I do my modified thumb or my modified diversified pisiform or whatever I do on you, you get a lot of musculoskeletal relief. But guess what? That's your heart area. And chiropractors, I'm telling you, this area is super important. And so is T3, that's lungs. So you can read for yourself what the different areas relate to. And you know, what do people come in with? I'll tell you what I saw very commonly. I saw a lot of gallbladder. I saw a lot of T4 even on people who had already had their gallbladder removed, because even though the organ was gone, the nerves weren't. Tons of stomach stuff, bad food combining, eating too fast, eating too much. A lot of pancreas. Everybody's addicted to sugar. Who doesn't want their hot, crispy creams? Spleen, I saw a lot of. I had a lot of people, nurses, worked in hospitals, people who worked in daycare centers, people with just very low immunity. Liver, very common. You're going to have a lot of alcoholics. You're going to have a lot of drug addicts as patients, just because it just goes with our society, unfortunately. You're going to have a lot of people taking a lot of prescribed medications and a lot of unprescribed medications. They can't metabolize those medications. It's having a bad effect on the liver. Students commonly suffer from T9 adrenal dysfunction from the constant stress of being a student. Small intestine is a victim of everything that came before it. How can you really digest properly if you have pre-existing blood flow issues, gallbladder dysfunction, stomach dysfunction, pancreatic? Don't forget, the pancreas is not just blood sugar. It's also the creator of all digestive enzymes, except what is provided by the liver and the stomach. But the pancreas helps digest every food product. So small intestines is a big deal. The pancreas empties right into the small intestine. 11 and 12 is kidneys. It's supposed to clean the blood. It's a lot to ask the kidneys to do, especially if the patient is they don't have enough water. They're dehydrated. And I had a great case years ago of a patient with low back pain. And we couldn't figure out what was causing her low back pain. I was not the first chiropractor she'd seen. The only thing I found on her was kidney involvement. So I started asking her if she drank a lot of coffee, because that'll dehydrate you, or a lot of Cokes, or a lot of alcohol. And she said, no, no, no. So we got to, well, what do you drink? And she said, nothing, including water. She was just dehydrated, and when she went on a 2-day program of drinking as much water as possible, and by the way, she hated that idea, all her low back pain was gone. Ileocecal valve, I had a patient who ate a huge tub of popcorn one night at the movies, and ate the unpopped kernels, and they got stuck in his ileocecal valve, and that created enormous pain. And ask me about my own ileocecal valve adventure. That's all I'm going to say at this time. Cecum, etc. Reproductive organs, not reproductive organs, but the glands, ovaries, testicles, that's L3. What a nasty place to put that. Colon is L4. How many people have colon cancer? How many people have prostate cancer or uterine cancer? How many people lose normal reproductive function too early? Man, this is a big deal. So we try to deal with that in the SOT practice. I think we're delivering more for their money when we do that. I like CMRT. I think it's a good thing to do, and we need to sort of steer our patients in into a more healthy lifestyle. I know most chiropractic students eat way healthier than the general population.